Thank you, Brites. Thank you, the organizing committee, for the invitation. It's always a great pleasure for me to be here with you. This event is now a milestone here, and it's a great pleasure to participate in the HIV Clinical Forum. So today it's up to me to open the activities of the day, but also to talk to you about the use of integrase inhibitors in pregnancy. So these are my conflicts of interest. I mean, my disclosure. There's nothing actually to disclose. And for those treating pregnant women, we know that many times it is difficult to find the ideal regimen, particularly for those who have been previously exposed, gets to us very late, she's already under virological failure. So these have always been the profiles of very difficult pregnant women, difficult to find an ideal regimen that could suppress viral load. But in the last few years, in addition to all that, we had an even worsening situation with those initial data on the possible association of dolutegravir with the neural tube defects. This is a time for us to find a way during pregnancy when we need balance, to find a regimen that is strong, powerful, effective, and safe, not only to the pregnant woman, but to the fetus. So, many times we extrapolated data. In my professional life, many times I use extrapolated data of men that were done in men, studies done in men or in non-pregnant women. We always miss women in studies. Since the last few years, they started to be recruited, but whenever they get pregnant, they are withdrawn. So data many times are extrapolated from studies that do not focus on this particular population. In the next few minutes, I will bring some news to you. These are the latest studies showing specific data for this particular pregnant population, pharmacokinetics, safety and efficacy data. So specifically about pharmacokinetics, I mean, we know that a pregnant woman is a different case. We cannot extrapolate a woman that whatever worked in a non-pregnant woman will work in a pregnant woman. So there's a series of physiological alterations, alterations in absorption, alterations in terms of distribution, metabolism, and extraction. Some things will increase and others will decrease, so that if we do not have studies specifically done on this population, we would still, swimming in the dark, if you will, and trying and making mistakes and all. But I will show you. And those who have seen before, you will be a review. For those who have not seen it, you will see it. And I will show you the hard time we had a few months ago. What have we got about it? We already have studies from some time, dolutegravir, showing that just like other antiretrovirals, there is a decrease in serum concentrations of these pharmaceuticals in the second and third quarters, but we do not need to adjust the dose. Raltegravir, however, should not be used QD during pregnancy. We do not have this presentation in Brazil, but should we have, we would still use it twice a day, just like we suggest for the darunavir, every 12 hours during pregnancy. What is new? I mean, we have data on bictegravir since 2 years. We've started to see publications on bictegravir during pregnancy. So this one was presented at CROI this year. This is data on pharmacokinetics and virological outcomes and viral suppression in 20 pregnant women. Despite the important decrease in the second and third quarters compared to postpartum, we do not need to adjust dose. We do not need to increase dosage because the minimum concentration, the minimum inhibitory concentration was above the 95 percentile in no pregnant women. It therefore tell us we do not need to increase the dosage. We had adverse effects in 7 women, degrees 3 or higher, but not associated to bictegravir. Some patients got to the liver without a detectable viral load, but showing that bictegravir should be included as a safe drug to be used in pregnancy. This is another very similar study, just introduced in July. Yes, 33 pregnant women on bictegravir, trying to show pharmacokinetic safety data, but also showing that despite the important decrease compared, week 6 and week 12, we do not need to do dosage adjustment. Everyone was there in the delivery with non-detectable viral load. That's another evidence that we will probably be able to use bictegravir in pregnancy. We do not have it in Brazil yet, but elsewhere it's been used, and it's likely that we will already include it in our treatment guidelines for pregnant women. Novelties on safety and efficacy for pregnant women, not to the newborn or the fetus. We remember initial studies with the raltegravir, particularly for late introducing pregnancies. Those with raltegravir would get quicker to the liver with a non-detectable viral load. A larger number of patients would get there with non-detectable viral load, and then we started the studies with the raltegravir with the same design. This one, for instance, IMPACT, it recruited pregnant women between 14 and 28 weeks, therapy naive. One was dolutegravir with a TAF, the other dolutegravir with tenofovir, and the other arm was efavirenz. And then the primary endpoint would be non-detectable viral load at delivery, and secondary endpoints would be those regarding maternal and fetal safety. So very quickly, just as in raltegravir, the arm with the dolutegravir, regardless of having TAF or tenofovir, was much higher than the arm with efavirenz. That was statistically significant, reinforcing what we already knew about raltegravir. Some other safety data showed that those on dolutegravir with TAF had less adverse effects than those on dolutegravir with tenofovir or efavirenz. So under the overall standpoint for any adverse effect, those with the dolutegravir with TAF did better. And here he shows events such as preterm delivery, small for gestational age, stillbirth, spontaneous abortion. So the arm on TAF did better than the tenofovir or efavirenz. And then other adverse events as well, degrees 3 or higher, maternal or infant. Those on dolutegravir had less effect than those on efavirenz. So the good strategy is to use dolutegravir. And all those studies follow the same line. This one is about the same thing, but instead of 14 to 28 weeks, it only gets those over 28 weeks, and only 2 arms, dolutegravir with 2 analogs and efavirenz. Let's say the primary endpoint in undetectable viral load, and secondary endpoint of neonatal and maternal safety. Those efavirenz is red, the dolutegravir is red. In all things, dolutegravir did better, regardless of viral load. The best one was dolutegravir. Regardless of CD4, the best one was dolutegravir. Regardless at what time they came with the gestational age, dolutegravir was very, very superior, reinforcing even further what we already knew. And then we had several ones. We already have a meta-analysis gathering all of these papers. We have Dolphin 1 and 2. I will show you Dolphin 2 data as well very quickly. Just to let you know that this is started to be studied in depth. And today we have enough robust data showing that dolutegravir during pregnancy is effective and safety to the pregnant women. And how about the baby, the fetus, the infant? What about the safety data? That's what I said in the beginning. Those working with this topic for longer, you remember in 2018, 2019, the world stopped, for pregnant women. This study it was designed to assess F5-related neurotube defects, but dolutegravir was incorporated for first-line treatment, and then there was an interim analysis that was requested, and to the surprise of everyone, the arm on dolutegravir showed a prevalence of neurotube defects than those on F5. And then we stopped it all. The WHO issued a safety warning, and we stopped using it here. So we went after, other data. The denominator kept increasing, so we started with the prevalence of 0.9, very different for those on dolutegravir in periconception. This is different from those using afterwards or on F5RN, so those who were not HIV positive. I mean, the time went by, prevalence went down to 0.6, 0.3, and last year they showed this in the AAS, showing a new update with the new cases. The higher the denominator, the more pregnancies we have, the higher the power to tell us whether that was real or not. And showing that those using dolutegravir at conception had a prevalence of 0.11. Those that did not use dolutegravir at conception, 0.12. Those on F5RNs at conception, 0.08. Those on dolutegravir at another time, 0.06. And women without HIV, 0.07. So practically, the prevalence is very similar nowadays. And from these results, the WHO started to suggest dolutegravir is first line for women in pregnancy, as well as the rest of the population. So theoretically, we should already be comfortably prescribing dolutegravir without fear or hesitance. So I summarized the 2 years of updates. They also did a survey in the Registry of American Pregnancies. Although they compiled data from several parts of the world, they have both retrospective and prospective data. They performed this analysis by January 2021. More than 21,000 outcomes. They compared dolutegravir against other antiretrovirals for those who conceived, those who used it on the first, second, and third semester to check neurotube defects, and there was no significant difference when we compared dolutegravir with other antiretroviral and comparing dolutegravir with the general population, both in the first quarter as well as the other quarters. Other outcomes were also assessed, such as live birth, stillbirth, spontaneous abortions, among other things, and there was no important difference. It kind of calmed us down by the time so that we could get back to prescribing dolutegravir to this particular population. Here we show this small chart. We only had 19 in the first quarter, among 517 exposures and percentages that are compatible with the overall population, both in Atlanta as well as in Texas, because those were the database they compare, as well as with other antiretrovirals. And conclusions, once again, dolutegravir was not actually associated with a neurotube defect increase. Brazil was not lagging behind, so we went after it. Our Ministry of Health also surveyed retrospective data on the pharmacosurveillance. More than 1,500 pregnant women were involved. 400 dolutegravir started up to the 8th week of pregnancy, showing that there was no defect on the neurotube. After the study was closed, they had 2 neurotube defect cases in Rio Grande do Sul, southernmost part of Brazil. They recalculated the prevalence, and the prevalence now is 0.18, including those 2 particular cases. And in Brazil, our neurotube defect prevalence is 0.06. For those who have not seen, we have the reports of cases from Edui and his team. This is an anencephaly case, and also related to dolutegravir in periconceptions. These are the only cases we have described. Dolomite was another study showing dolutegravir outcomes related to birth. Studies considering several other countries, and they wanted to see other outcomes such as preterm, extreme term, low, small weight at birth. I mean, would there be any difference, those starting in periconception and dolichography first quarter, second or third quarter? They find out that no, among all outcomes, there was no statistical differences regarding the time the dolichography started to be used during pregnancy. Something new. I mean, and you will see from now on data from cabotegravir. This is IV cabotegravir. Patients were recruited for PrEP, but showing that it was safe. These, I mean, we have pharmacokinetic data. There was something else presented at CROI this year. I didn't bring it, but we will certainly see, and here we will see pregnant women using cabotegravir with HIV or without HIV. So we are expecting to see the next chapter anytime. That's another systematic review showing other outcomes, not only neurotube defects, or those I mentioned, those acronyms, or showing that those using integrase inhibitor did not have different outcomes of those using analogs or protease inhibitors. So once again, integrase inhibitors are safe for use in pregnancy. See, so this is a registry. I brought a print of it. This is up to date. They now update every 6 months. They compile how many new exposures, how many pregnancies. Now you need to have at least 200 pregnancies with that antiretroviral to be included in the chart. So now we already have a bictegravir, we already have alpha-tegravir, we have raltegravir, dolutegravir. We still don't have cabotegravir though. But none showed important difference compared to the other antiretroviral, regardless of the time when it was introduced during pregnancy. It was preconception, first, second quarter, so we're doing well. Another topic, I will speak even faster because we will certainly have a specific session, and it is maternal weight gain in pregnancy. Some studies showed that there's an association of a greater weight gain with integrase inhibitors, but among those, women and black women gain more weight in some studies. So we also have this kind of endpoint in studies such as impact. Remember, I showed you impact, the 3 arms, dolutegravir or tough dolutegravir with the tenofovir and a 5-year range. So the same study, in addition to the virological efficacy of other outcomes and endpoints, they also check the association with weight gain. And those on tough, just like other studies, gained more weight than those on dolutegravir with TAS, gained more weight than a 5-year range. And then it shows who gains more weight or less weight. Gaining much weight is no good, but not gaining not gaining weight is not good either. So both outcomes are associated to complications. So we need a balance in our regimen. We cannot gain a lot of weight and we cannot gain weight at all. So for what is recommended, even those gaining more weight, which was this arm, gain less than what is recommended per week during pregnancy in non-HIV individuals. Those gaining less on a 5-year range, those gain more on dolutegravir. Another way to show the same data, those who gained more or gained less, the two ends are no good at all. Other studies talking about weight gain in pregnancy is SMART. In this SMART study, there was no gain difference for those on integrase inhibitor, dolutegravir, or other antiretroviral drugs. You see, this is a different population. CEPAMO also started with this endpoint, and there they also showed that just like in impact, those on dolutegravir gained more weight, and they calculated week after week, and they check what this weight gain is associated to. Much of it may associated to microsomy hypertension, and in the dolutegravir arm, it really happened. So in this particular population, we must be aware that a pregnant woman already got there with 120, 140 kilograms. She's gaining much weight, so we need to monitor these pregnant women more closely to find out what's going to happen. But according to HHS, this is dolutegravir weight gain. This dolutegravir-associated gain has to do with the disease, because when he compares with antiretroviral that doesn't allow for weight gain, it seems that the other arm is gaining too much weight. But comparing against those without HIV and comparing to the weight gain recommendations, this group didn't gain much weight at all, or not too much actually. And the last topic, what are regimens being recommended around the world? Today we know that we only have, in Brazil, we only have dolutegravir for first line. We have raltegravir, but in pregnancy, first line is dolutegravir. Up to the latest updated dolutegravir was first line, and now it is also an alternative. Bictegravir, it is still hasn't got enough data. It is sufficient data to recommend. I believe that in the next update it will be recommended. And raltegravir, these are not recommended, although. So I mean, it means that the women who's willing to get woman who's willing to get pregnant and is treatment naive may start with dolutegravir. Raltegravir, bictegravir we should not start with, and cabotegravir neither. But if she's already pregnant, should she keep it or not? If she has non-detectable viral load and is well tolerated, we will not switch, with the exception of abacavir. You might need to switch because of cobicistat, and if you decide not to switch, you will have to check the viral load at least every month or every 2 months. We do not have it here, so this is not a problem of ours yet. This is my last slide showing the novelties on dual therapy in pregnant women. It's not yet recommended, but it is already brought up. If the woman is on dual therapy, she's doing well. 1 year after suppression, you might leave it, but you should check the viral load. And Dr. Brites will certainly present in the next month our own data in the European Congress, dual therapy in pregnant women, showing that we were quite successful in the results of the outcome of those pregnant women with dual therapy without much alterations to the mother or to the fetus. I thank you for your attention, and I'm available to answer questions that you might have. Thank you.